Okay. Hi, welcome. Glad to be back with you this evening. Welcome to those who've been with us. Welcome back to those who've been with us. Welcome if you've never been with us. Since we've last been together, our host Glenn, as you know, had a terrific birthday. And last time we were together, the audience presented Glenn with this terrific birthday present. And it says, Glenn Grossman, can't read in reverse. You mean the world to us, your COVID-19 audience. This is the world right back at you, Glenn, because you mean the world to us. Thank you again for everything, for holding us in your hands all this time. Many of us went to outer space today and we're back on Earth. And Glenn, hopefully, like you said, you have good news and we are glad to be back on Earth. And if not, July 20th, we get to go back to outer space and you may choose to stay there. So anyway, here goes. Glenn Grossman is an epidemiologist with over 20 years of experience. While pursuing his doctorate in epidemiology at UNC Chapel Hill, Glenn served as an epidemiologist on staff at the UNC Infectious Disease Clinic for 2 years and taught epidemiology and advanced analytics at Duke Medical School and at UNC. He has been involved in epidemiology forecasting and advanced analytics with Bristol Myers Squibb, Sanofi, Novartis, Medicare, Medicaid, Veterans Health Administration, Military Health Service, the CDC, and other programs within the United States and abroad. All views expressed today are his own. So today, Glenn, we are going to be talking about a lot. A lot has happened. I can't even believe it in the past few weeks since we've been together. We are going to be talking a lot about this Delta variant. We're going to be talking about to mask or unmask. That is the question. We'll be talking about to boost or not to boost. That is the question. And many other questions that our audience has sent in. So thank you to everybody who has been really terrific in sending in questions these past few weeks. And if you have questions while we are having our conversation, please send them to me via the chat button at the bottom of the screen. And I will do my best to weave your question into our conversation so Glenn can answer your question while we speak. Okay, Glenn, let's kick it off. Could you please update us on the COVID-19 pandemic, the variants of concern, the vaccination in the US and abroad? In particular, could you please tell us how the world is dealing with the Delta variant?
Thanks, Rebecca. And thanks as always for all the great work that you're doing. And thanks for that award that you gave me a few weeks ago. All right, let me share my screen here. All right, let's just jump right into this. All right, so here's what we're looking at. So this is the CDC's website. Right now, I just overlaid the United States cases with the percent positivity. The percent positivity rate of tests is good because I find it's an early indicator of a rise in surges. So we start to see jump in it in first. As you recall, we've had sort of like 3.5 surges. We had that first surge back last year, March, April timeframe, and you see it extended a little bit past that. And then we had the summer surge, which was very different. It was regional. The first one was everywhere for the most part, with it hit some places harder than others. The summer of last summer was mostly hit the South, and I think it was the Midwest, but it didn't hit the Northeast and some other areas nearly as hard. And it hit the younger people a lot more. They were outside, they were going to bars, and so it was mostly a lot of younger people. So we didn't see a rise in deaths as much. In fact, let me overlay that because I think that's more interesting. So if you'll notice, the first surge, we weren't really doing very good testing. So don't pay too much attention to that in terms of the death rate. But what's interesting is the death rate here, you see as a proportion that not as many people died as we would have expected based on that first surge. Then the winter surge that we just had came along, and then we saw an uptick in the death rate again. That was more what we were expecting. And so now the question is, well, here comes, we had this little surge that hit back in like April or so. And that was just due to the UK variant coming around, to some states were reopening a little bit too soon and things like that. And so you saw that the death rate wasn't really going, because it was mostly, again, the younger people that were mostly being infected. But now here we are, July, which is a little bit past where we were last year when that surge was happening. And if let's zoom into that. So you can see that we're just starting to see an increase in cases. We aren't seeing an increase in deaths yet, but in some states, in fact, I can go specifically, in some states you can see that they're really being hit hard. In fact, there's a better way to look at this. I like the New York Times website here. So when you look at the total cases right now, you can see that there are a few, this is the county level, you can see that there are some clear hotspots around the country. The darker the color, the hotter it is in terms of the number of cases that there are. And so you see that some states, even that are represented here, or here rather, some of these states, even if the state seems like it's elevated, you can see that within the state, some counties are very hot, whereas some counties are actually not nearly as bad. And in contrast, there are some states where, and what's an example, where maybe Montana isn't showing up here as something that we need to be worried about, yet there are specific counties within Montana that are really bad. And so we need to be looking at this as local outbreaks that are really hitting. And you can see that some places are getting hit harder. They do tend to overlap a lot with the areas that are vaccinated. Where do I want to see this? I can show it actually on this one. So this is the county level at where the cases are. If we switch here to vaccinations, you can see that there's a lot of the same overlap in terms of where it's hitting. There's a lot of counties you can see with very low vaccination rates. They tend to, unfortunately, there tends to be a political component to it at this point, so that Democrats have been pushing it hard and Republicans have been more averse to vaccinations. And so unfortunately, that's reflected in the uptake. And even you can see this at the state and county level when you look at it. But so right now, it's you can see where the hotspots are. Of more interest, I think, is this view, with what the New York Times is calling the risk level. But this basically overlays the caseload by county with the vaccination rate by county. So if counties have a lower vaccination rate and a higher caseload, then they're darker here, they're purple. And if they have a low, if they have a low case rate and a high vaccination rate, then they'll show up in green. So you see that even some states like New Jersey that has a pretty high vaccination rate, when you overlay the specific counties of the vaccination rate by the caseload, you still see that there's not any green, or maybe there's only one county that's green, Mercer County, where Princeton is in New Jersey. But otherwise, it's mostly yellow. And so you can see that there's wide variation across the country. This is July. Again, I'd like to repeat that it's not really flu and cold season. It's not pneumonia season. So the fact that we're seeing this at all is extraordinary. One thing that's interesting is that, again, what we're seeing so far is that it's similar to last year, where there's definitely an age component. I don't know if I can pull up a picture real quickly. It's very hard to see with what's going on. The data is not very good here. But one thing that you'll notice very clearly here is when you look at the second surge that hit last summer, the ages that were most driving it were the 18 to 29-year-olds, which is the dotted lines, and the dash lines, the green dash lines, which are 30 to 39-year-olds. There were also some 40 to 49-year-olds that were driving it as well. But the majority of the spread was by these younger people who are much lower risk of severe disease or hospitalization. And that's why we didn't see as much hospitalization or severe disease come out of that. In contrast, you see that there was a much larger number of older people who got hit in the fall and winter. And so now, even though the data is not very good right now in July, it is what's really driving it in the states that we're talking about is that it's younger people. So when you look at the hospital data or talk to people in the hospitals in Arkansas or some of these other states, what you see is that the people who are being hospitalized tend to be much younger because those are the ones who are getting sick. And it also makes sense because the older folks are the ones who are more likely to get vaccinated. So between the vaccinations and just the behavior that we saw last summer, it just makes sense that the rise in hospitalizations are mostly among young people. All right, let's switch to global. All right, so global, the big story is, let me show a map. What we have been talking about previously is that this is a seasonal disease. And so for the last few weeks, the darkness, so the darker it is here, the more cases there are. And so they were going away in the Northern Hemisphere and shifting towards the Southern Hemisphere, generally as a rule. So the Northern Hemisphere was getting lighter and the Southern Hemisphere was getting darker. But now what you're seeing is the rise of Delta again over the last few weeks. And so you can see like United Kingdom up here, which was doing pretty well because of their lockdowns, has started getting dark again. Similarly, some other countries in the Northern Hemisphere have also started to have an uptick. In fact, I pulled some out. You can see here, whoops. In fact, let me shrink it a little bit. So here's where we are now. Generally, the surge is varied a little bit globally. The first surge hit a lot of the world roughly at the same time, but this was before there was widespread testing. The second surge only hit some countries. A lot of countries were spared. The fall winter started in different places at different times. And so you can see that the peaks really started hitting at different times, which is very interesting. The UK, or rather this was Cyprus, but let me click on the UK. So the UK had the Alpha variant. This was the UK variant that hit them really hard in January. They locked down really hard, and that's really what stopped that spread. But then the Delta variant hit, and the Delta variant hit while they were still mostly locked down. And so they've started easing restrictions. They plan to completely end restrictions on July 19th, so within another week or so. And so it'll be really interesting to see what's happening. You can see that they're just right now in the beginning of the surge over there with UK. And so this is potentially problematic. So all eyes are on UK, particularly when they end their restrictions. We're going to see how it impacts the spread, how it impacts hospitalizations. Right now, there's not a lot of an enormous amount of hospitalization in UK, and it's because primarily the people who are getting sick are the younger people. The vaccination rates, in fact, let me switch to vaccines. So this is people fully vaccinated. So you can see in the United Kingdom, they're roughly where the United States is. It's roughly at a little over half of the people in UK are vaccinated, but among people over the age of 65, it's a much higher percentage. I think I pulled out some slides on that, which we can talk about a little later. Here, let's look at it as a map. So you can see that there's wide variation in terms of the vaccination rates, unfortunately. So we need to do a better job of vaccinating the world. But you can see that that in the Northern Hemisphere, so Canada, United States, we've vaccinated quite a lot. Unfortunately, we've sort of are hitting a wall, and there's a lot of vaccine hesitancy for the remainder now. Europe, it's even they're even slower, and there's the same type of thing. But yeah, so much of the world you can see is still struggling to vaccinate the population. Interestingly, when you look at the Southern Hemisphere, Chile and Uruguay have been very good at vaccinating. However, despite that, when you look at the confirmed cases, you can see that they're doing a little bit better now, so that's good. But they got hit pretty hard over the last few weeks. So it's interesting. So it's currently July 10th. So that's the Southern Hemisphere. So I just loosely, if we were to look at what this might look like for the Northern Hemisphere, then maybe we're talking about like what January 10th would look like. So the Southern Hemisphere got hit hard, but it looks like it's starting to reduce a little bit. And the colors are starting to come down in the Southern Hemisphere, at least in South America. When you look at Africa, so Southern Africa, you can see that it's still getting dark. And so they're definitely not out of the woods there. When I look at the reproduction rate here, so this is, whoops. So this is how fast the variants are spreading. Anything above 1 means that it's spreading faster and it's growing. Anything above 1 means that it's lowering. And so the fact that it's lowering in South America is really good news, because even though it's winter time there, it means that they're past the peak of their curve for now. I'm not sure how large the Delta variant is. I can look. Not all countries are very good at reporting Delta, but let's see. Some of them were a little while ago. So you can see this was at the end of June. Peru was reporting that almost, 100%. I'm not sure how to interpret that, but because Peru has shifted a lot. But Peru had a lot of Delta variant. Chile was not reporting very much. Brazil was reporting 0. Let's see what it looks like here. This is probably better. 100% than 2. Yeah, I don't know how to interpret, because I don't think Peru is truly 100%. It may be, but I don't think that that's the case. In contrast, United Kingdom, 98%. I trust that. That's been growing for a while. United States were at 87%. Mexico is at 62%. Canada, let's see if there's a recent time. The last that they reported was they were at 47%, which was July 8th. So that was a few days ago. But basically, the UK variant is hitting, or not the UK variant, rather the Delta variant is hitting a lot of countries really hard. The really interesting thing about the Delta variant, now let me just point this out, is so one thing, whoops. All right, so one thing that you'll notice is that previously there was a lot more diversity of variants. So if you look here, we had all these different variants. We had alpha, beta, epsilon, eta, kappa, zeta, iota. There are lots and lots of different variants. But now alpha, which is also called B117, and delta, which is also called B1617.2, and we also see a little bit of P1, which I think was the Brazil variant. And also P1, I think, and so anyway, these 3 are driving out the other variants. So even though there was a lot more diversity, when you look at all these other colors that were here before, now over the last week, these 3 represent the vast majority. And this is from June 19th was the last reported data. And so now the fact that when you look at the picture that I just showed you, where we have 87%, 88% is Delta now, let me show what that means in terms of here. All right, so here's another way of looking at this. Is the same. These are some of the countries that we were just looking at, but these are the different variants that have been reported. So previously, you can see that there was much more diversity. So others represented the vast majority. And then the alpha variant, which was the UK variant, hit much of Europe, but there was still a lot of diversity of all these other variants. You can see, like, at one point in Germany, 98% were other, and it was a much smaller percentage of these key variants of concern. But over time, what's happening are that these very contagious variants are driving out the other variants, and they're almost driving the other variants to extinction, which is so interesting, because now look at how solid this is becoming. When you look at the Delta variant, which is this aqua, the Delta is now 98% in UK. UK has almost no other variants. Another month or 2 of this, and it could literally make all the other variants in UK go extinct. Similarly, we're seeing a drive that looks exactly the same in almost every other country. United States, where we had all these different variants, the Delta variant is now wiping everything else out. It's just so contagious. It's just super spreading much faster than everything else. And so the other variants don't have a chance to get a foothold in. And so this is potentially really good news, because it means that the Delta variant might become the top variant, the contender that's still in circulation in the fall and winter. The Delta is still evolving. So now we have Delta Plus. There's another one that we might talk about, Lambda here, that's interesting in Delta. only is a few mutations away from some of the key mutations of Lambda. So that might be something that we might see. But the reality is that all these other random variants that we were worried about in terms of what might be able to evade the vaccines, if all we're left with is Delta or some of the variants from Delta, went in fall and winter when we have a next surge that a lot of people are predicting, then this is going to make it so much easier for vaccines in terms of developing a booster shot if we need it, and just in terms of understanding what the future risk looks like. Because if once we get herd immunity essentially to the Delta variant based on vaccines and just people just getting infected over the next 12 months, that could be the end of the major pandemic for the time being. So we've talked previously that the flu of 1918, which was H1N1, I think it was H number X N number, which is that format. All flu that's in that format that has arisen every year since then, all pandemic flu. So anything like avian flu or swine flu or any of these things, all came out of the flu of 1918. They were all different variants and all things that came out of it. With COVID, we might have, with COVID-19, we might have additional variants that pop up years from now, but this Delta variant is so effective at driving all the other variants away. This could be really, there's a really positive side here that this could really be beneficial for us, so that we might be talking this time next year. This could be, we might be all, I mean, I think probably by March of next year, we'll probably be done with this for the short term, unless there's definitely still some opportunity for things to come out. But we can talk about that later if we get into peak fitness or that kind of question. But for the time being, the fact that when you look at United Kingdom, that it's really driving out all these variants, I see this as really beneficial. Look at all these other ones of concern, these variants of interest and concern that are now down to like 0%. You have 0% for a few weeks or a couple months, and these things go extinct. So that's good news. All right, it's let me see if I have anything else real quickly to talk about, and otherwise we can just open it up to questions. We talked about that. We talked about, let me just go through some of these other things. Yeah, no, that's it. We can open it up to questions now, Rebecca.
All right. So Glenn, the Delta variant, many believe, arose from India, right? So why did India's surge end so quickly? Are Americans just exaggerating the risk of Delta? Can you explain more about what's going on there?
Yeah, so that's a really interesting question. So if we recall, well, first of all, when you look at any map looking at, or any graph looking at India, in fact, this isn't a good one. Let me come back here. And I'm just going to restrict it. Well, just in case you want to come back to here. Let me open up this one instead. All right, I want confirmed cases, 7-day rolling average. All right, so what we're looking at here is India. Oh, and United States, you can see, I don't know if I just mentioned this just a little earlier, but you can see that we're starting to have the uptick again. So the surge is happening. It's aggregated and reported on this website at the national level. And you saw that it was really something happening at the state and in particular the county level, the surges. And so because of that, when you look at national level data, it sort of hides and obscures what's going on. And that's why county level is so important. But I think that within another month or so, we'll see a bigger rise just because it's spreading so fast. But it wouldn't surprise me if this summer looks a lot like last summer in terms of the county level spread, and that we don't see a lot of hospitalizations yet, and that the hospitalizations are mostly among the younger. But anyway, going back to India for a second. So India had the Delta variant and was rising. We had a bunch of different variants there. The Delta came out of it, but yet it reached a peak and then started coming down. What we know is a few things. One, they were doing an extremely poor job of testing. And so we think that maybe this only represented maybe as little as 10% of the actual cases that occurred. So the peak was probably far, far higher. But even despite that, the question is, well, have they reached herd immunity? And there have been some interesting investigations looking at this. This one article in particular was really interesting. It was looking at the seasonal role of the different surges that have taken place in India, especially by state within the country. And so there have been two big surges there. One happened in the August, September, October, November timeframe, and it was overlaid with the monsoon season. Then when you look at low humidity periods, it varied a little bit. When the new surge hit, it really hit during a part of the year that really promoted it, I think. The seasonality has since shifted. And when you looked at the spread across India, it also corresponded strongly with the seasonal aspect in terms of what you're looking at. The downturn since then has also corresponded a lot with the change in seasons. And so there is anticipation that come September or so again, when the seasons change in India, that there might be an uptick again. In the United States and much of the part of the world, we assume that the increase in how contagious the virus gets, or what we call in epidemiology, the reproduction rate, the R value, that it increases by approximately 30 to 40% between summer to fall, winter, when it's at its worst. And so because people spend more time indoors and there's different humidity levels and whatnot, the exposures change. And so right now, we think that it's largely a seasonal component that's specific to India. In fact, I think that there was a better, well, they broke it down. I like this article, they broke it down. So the quick answer is that they probably did reach a sort of herd immunity on the short term, but it was impacted by the seasons. And there is an expectation that there will be another surge come September. I don't think it's going to be as bad as what they just had. It may be, but it's still unclear. The data in India is very, very poor, so it's really hard to know a lot about that. But that's the best that we have so far.
Okay. So thank you, Glenn. So let's jump into the question on so many people's minds about really how good are the vaccines against this Delta variant? And you're talking about, you showed us about the surge in hospitalizations previously. Will there be another surge in hospitalizations? It may be in different parts of the country. What are your thoughts on that? And maybe now is a good time to talk about masking. And now there's this controversy about the booster shot. So take us through sort of all those different components.
All right, so let me do a quick refresher on how contagious the virus is and the reproduction value, the R value that we talk about in epidemiology. So when R is greater than 1, it means that you have a surge, you have an increase in cases, and so the virus is more contagious, and in the sense that that if one person gets infected, they will infect more than one other person. When it's R equals 1, then that means on average, one person who's infected will on average infect one other person. Then that means that it's flat. That's the peak of the surge, or if it stays flat for a while, that's R equals 1. And when the surge is going down, then that means R is less than 1. That means that for each person infected, they infect less than one other person. Interestingly, among children, prepubescent children, we found that R tends to be less than 1 for most of the variants that are out there. We don't know for Delta yet. We know that Delta is approximately 2 to 3 times more contagious. So the R is 2 to 3 times as high as the variants that were commonly spreading this past winter in the United States. So because R was 2 to 3 times as high generally, it could be the case that for Delta, the R is above 1. We don't know yet. And so that's something that's still going to be on a lot of people's minds when we open the schools again in the fall. But generally, using historical data on what COVID looked like in the schools that reopened, generally kids were, if one kid got infected, they were less likely to spread it than adults were. and so they were less likely to be contagious, so significantly less likely to be contagious. And so that's something to keep in mind. But anyway, so when R is greater than 1, you get a surge. The bigger R is, the steeper the incline. And so if R gets up to 5, 10, 15, 15 would be enormous. That's like measles territory. Then you're looking at almost like a straight line up. All right, so what are we talking about here? So another refresher, the original Wuhan variant that hit back in March, the best estimate that we have was that the R value was between 2 and 3. So we're roughly estimating 2.5. It did vary a lot by location. So for instance, if you lived in New York City and this was early March before anyone knew anything about SARS-CoV-2 spreading, except epidemiologists, but like if you were just a random person on a subway, the subways were packed, and if one person was sick, they could have easily infected a dozen other people around them on the subway car. So on average in New York City, each one person infected a lot more people than say rural Kansas. In fact, there was some good work done on, there's a bunch of different estimates. It was really hard to know specifically what the R value was early on. But this is one estimate. This was from a website that was previously live. It was RT Live is what it was called. And they estimated that New York State, on average, including New York City, but the state as a whole, for every one person infected, they would infect 5 or a little bit over 5 other people on average. Some people who were infected would infect no other people, but then there were also super spreader events, so that one person infected might infect 30, 40, 50 other people around them. And so, but what you can see is that this varied dramatically by state. So when you look over here, what is this, Alaska? You can see in Washington, these numbers were very low. That means that one person infected would only infect one other person. When the R value is so low, you expect it to slowly increase, but it's almost essentially flat. It's a very, very, very shallow increase at that point. Whereas when you have an R of 5, like in New York, or an R of 4, like New Jersey, it's a very rapid increase. Another website, this one was using machine learning to try to figure things out. They estimated that in New York, it was between 3.5 to 4, so roughly 4, which was a little bit less than the 5 that we saw from this other website estimating it. Again, it's really hard to estimate these things, especially early on when we didn't have good testing data. So it was just a challenge to figure out what these numbers are. But you can see, looking at here, the one again is this magic number. If it's over 1, then it increases. If it's under 1, it decreases. And so the further away from 1 it is, the faster it increases. And that's why New York got hit so hard, so fast early on. New Jersey also got hit. You can see we were above 2.5, but you can see that it varies. Within the states, some of the cities of interest that varied a lot. So for instance, New York City in particular was well above 5 in terms of the average R value. In terms of the cities that were above 3, you can see that these are counties, I guess. New Jersey, Essex County got hit really hard. It was above 3. New York, Nassau County, Suffolk County in New York, Philadelphia got hit really hard. A county in Texas. Oh no, that's not this Texas. That's Philadelphia. Westchester County got hit really hard. Anyway, you can see that there is huge variation, is what I want to point out here, because there's a lot of cities and counties that didn't get hit very hard. So for instance, Santa Clara was only at its worst when you were looking at R naught back at the beginning, was only slightly above 1. It looks like it was maybe 1.5, just slightly above 1. And so that means that all you had to do were put minor adjustments in place, maybe mask wearing, some restrictions so that there was less mobility, so people were staying home more, and that would very rapidly bring it down below 1 and stop the outbreak. And so the 1 value is really important. Globally, you also see this wide variation. It's a little bit hard to see the screen, but you can see that there were some countries like this is China that had really high numbers. This was over 3. And that there are other countries like this is Cuba that we were looking at that were just slightly above 1. And so there's just wide variation that occurs naturally because of physiological aspects of people that we might not know, or because of cultural aspects in terms of the packed subways versus not packed subways. All right, Why is this important? And here's what I'm coming to. No, I will not come to that. I will come to this. What everyone is wanting to know. Here's the Delta variant, and here's the results of recent studies. The two big ones have come out of the United Kingdom and Israel. The United Kingdom, I trust a little bit more just because they have a lot more data. In fact, the reason that they have more data is what we were looking at here. Let me put it here. And the reason that we're looking at United Kingdom is because you see they are really surging with Delta right now. So they have much better data than anywhere right now in terms of looking at this. There are a lot of, in terms of Europe, I had pulled them out separately. You can see that Europe, Netherlands is surging. A lot of states are really surging right now. And so we're gonna have some better data coming out of there soon. But for now, UK has great data. Oh wait, this is we want to see the confirmed cases. Anyway, let me go back to where we were. All right, so the key at the end of the day, what most people are interested in is how well does the vaccine prevent hospitalization and death? And what we found is that the Delta variant, the mRNA vaccines protect against hospitalization 96%. And so another way of saying this is that among people who would have likely been hospitalized without the vaccine, now only 4% of them, if they get infected, would be likely to be hospitalized. So that's really enormous. That's really all that matters, the hospitalization and death to me. If someone gets sick and not hospitalized, it's unfortunate and it feels really annoying and they're knocked off their feet for a couple of days, maybe a week or more, but it's not the end of the world if they don't need to be hospitalized. And so when you look at these other metrics, keep that in mind. So when you look at vaccine effectiveness against symptomatic disease, so against symptoms, it's 79% effective, these mRNA vaccines. So that means that 21% of people who get infected with or rather 21% of people who are exposed to Delta will get symptoms from it, even after, who would, let me rephrase that. 21% of people who would have gotten symptoms previously, who are now, let me rephrase this one last time. Among people who would have gotten symptoms previously who are not vaccinated, only 21% of those people now will get symptoms if they are vaccinated, if that makes sense. So a much smaller number.
Can you say that one more time?
Absolutely. So
say that again.
People,
so let's give an example.
So
let's
not
give an
everyone,
example of somebody is, let's give an example. Let's give somebody a fictitious gender and age, and let's say they are vaccinated. What percentage of these people are, okay, all right.
The reason is it varies by age and gender. The reason I was struggling with the wording a little bit just now in real time is that just because someone's exposed to the virus doesn't mean they're going to have symptoms, right? A lot of people are asymptomatic, right? And so this is not saying what percentage of people will be symptomatic. This is saying how protective it is among people who would have been symptomatic. So that's a slightly different number. So say half of the people are symptomatic. I don't know exactly what the number is, but if we assume that half of the people who get infected without the vaccine are symptomatic, so the 50%, among those 50% who would have been symptomatic, now only 21% of the 50% are symptomatic. Does that make sense? All right, so that's a little clear. Let me take this one step further now. All right, so in addition to that, so for symptoms on an individual level, that's what's important. Really, the bottom line is hospitalization for an individual person. This is great news. However, in terms of spreading it, this is the other thing I talk about in terms of herd immunity. Because if someone gets the vaccine and they can still infect other people, then that's not so good, because then you still promote the spread of the virus. You could be a vaccinated person could be sitting next to an unvaccinated person. The vaccinated person could be infected and asymptomatic and could infect the unvaccinated person who has full-blown COVID-19 and ends up needing to go to the hospital. So these two things are important, not just how well it protects the person who's vaccinated, but also how well does it protect the people around the person who's vaccinated, if that makes sense. And so there's a few things of interest here. All right, the first thing to keep in mind is not here. The first thing to keep in mind is this idea. Around 50% of people who are infected and vaccinated can still transmit it. So this is actually really good news. Another way of saying this is that people who are vaccinated who are vaccinated and get infected. So say they're just infected despite being vaccinated, they reduce how infectious they are, how contagious they are by 50%. But even better is that a lot of people aren't infected at all. So that means if only, so we have some good data coming out of UK and Israel. The data out of UK I trust a lot. I'll share the Israel information too. But so basically the best information we have is that the effectiveness against infection ranges from around 50%, 55% to 70% with the mRNA vaccines. It's 60 to 70% with the AstraZeneca vaccines. But for 2 doses, which we're really interested in fact, I should be putting this here, for the 2 doses, it's really 70 to 90% effective. So that means among people who get vaccinated, if they would have been infected without the vaccine, now they're only 30 to 10% likely. So on average, I'll say it's 20% likely to get infected if they're currently vaccinated. Among those who are infected, so among the 20% who end up still being infected, 50% of those can no longer transmit it. So that means that in total, among people who are vaccinated, we expect a 90% reduction in transmission, which is enormous. What this means is that in a place like New York City, where there was over 5, an R naught of 5, again, what this looks like here, if the R is over 5, so this is New York City, it was over 5. If the R is over 5, then what that looks like here, whoops, not here and not there. Then what that looks like here is that the Delta virus, which we think is maybe 3 times as contagious as the original Wuhan variant. So if the original one was 5, if you multiply that by 3, then that gives you 15. That means the Delta variant, without masks, without physical distancing, without anything, could be as high as measles was. But if you get vaccinated, then you reduce the R, the effective R, down to slightly above 1. This is without masks, this is without physical distancing or anything. In places where the R value was originally 3, if you multiply that up based on how contagious Delta is likely to be, and then remove that from the vaccines, then that makes it less than 1. So all of these places that were 3 or less, which is the vast majority of states here, you can see under this assumption. So here's 3 here. That was every state except New York is what they estimated. When you see here with this other estimate, there were only a handful of states above 3. In particular, I'll call them out. This was New York, New Jersey, Illinois, Florida, Indiana, Louisiana, and then Connecticut and Texas, and Georgia. Yeah, Georgia was right on the edge. That means that these might be the only states that would still have spread among vaccinated people. So this is potentially really, really good news. If we take this one step further, and so I said, so 3.33 is the cutoff of what what 1 looks like, so that you have no spread. Now, so obviously this is going to vary tremendously by county in terms of the vaccination rates, in terms of all these other things going on. But here's some takeaways that I pulled out of this. So 1, among vaccinated people with the mRNA vaccine. Oh, by the way, the Johnson & Johnson vaccine in the United States is very effective, but not quite as effective as the mRNA vaccines. We don't know yet because the data is not quite as good, simply because there were so many less people who ended up getting the Johnson & Johnson vaccine. At a high level, let me come back here for 1 second. At a high level here, we have 70 to 90% protection against infection, and for symptoms, I forget what, for symptomatic disease, it was roughly 79% protective. In contrast, the Johnson & Johnson vaccine is roughly 55%, maybe 60% protective. So it's not quite as protective. We don't know yet how protective it is against hospitalization or death, which is what we really care about. But so that's still something we don't know about. However, based on these things, I did some of the math in terms of what this could look like. So there are approximately 54 million people in the United States over the age of 65. Right now, 79% of people over the age of 65 in the United States have been fully vaccinated. That's 42.7 million people. That's a lot. 11% of people over the age of 65 have not been vaccinated at all. That's 6 million people. 14%, based on just a previous data, around 14% of people who are infected and not vaccinated can be expected to be hospitalized. That's just the rate. If you're over age 65 and you're infected, then on average, you're likely, roughly 14% of them are likely to be hospitalized. However, people who are infected, who are vaccinated, people who are vaccinated only have a 0.6 chance of getting hospitalized. So it's a dramatic, less than 1%. Dramatic reduction here. So everyone who's vaccinated over the age of 65, this is really great news. All right, what does this mean in terms of actual numbers though? So if all people over the age of 65 are exposed to Delta, this may or may not happen. This is a very aggressive assumption. However, we do know that COVID-19 in some areas where the R naught was high, the numbers, if people start going back into the subway at some point in New York City, and people are not wearing masks, then it's plausible that these numbers could jump high again. But so that means that the exposure level could go way up in many different places. But so what that means is that among non-vaccinated people over the age of 65, if every single person were to get infected, then you'd have 840,000 hospitalizations, and you'd have 240,000 hospitalizations among people over 65 who were vaccinated, just multiplying those numbers out. What that means is that 78% of people who are hospitalized will be unvaccinated. And interestingly, when you look at Seychelles and UK and some of these other places where the vaccination rates are high, you end up seeing around the same statistics. Around 80% of people who are hospitalized are unvaccinated. If around 20% of hospitalized patients over 65 will die, that's what the number was previously in terms of the rates of the fatality rate among people hospitalized with COVID-19 over the age of 65. It was roughly a 1 in 5 chance. Then if you just multiply that out, we don't know. It could be the case that the vaccines are still protective of, so even if someone's hospitalized, maybe it lowers the risk of dying. We don't know that yet. But right now, if we multiply out the same old statistic, then that means that you'll have ultimately 168,000 additional deaths among non-vaccinated over the age of 65, and you'll have 48K vaccinated over the age of 65 who will die. On average, previously, I think roughly half of the hospitalizations that we had were over age 65, and roughly half, a little bit less than half, were under age 65. And so that's going to shift now because the under age 65 are not getting vaccinated as highly. But these numbers, what that means is that the peak numbers we're looking at here are going to be a lot less than what we had previously. However, it's not like it's over. So we could have still more hospitalizations. It's not going to be as bad as it was cumulatively over the last year, but 200,000 more people dying in another surge in the next 6 months is still nothing to sneeze at. And again, this is just highly estimating the over 65. I'm confident not everyone's going to get infected, so this number is a little bit overestimated, or maybe potentially fairly overestimating, but it's not looking at people under age 65 at all. So when you add those back in, you'll probably have some kind of surge, but that's where we are.
Okay, well, thank you for this deep dive as far as Delta goes. So Glenn, I'm going to throw some scenarios your way as far as masking goes. And now that we know a bit more about Delta, Lots of offices are now opening back up. People are going back to work. So I'm going to throw some scenarios your way and you tell me what you would do. What would Glenn do?
Right.
WWGD. Okay, here goes. Okay, so here's a scenario. Someone lives in a household with no children and no, no particular at-risk individuals. Everyone in the household is vaccinated. Okay, so they're going back into an office where the employer has required that everyone is vaccinated. Would you wear a mask in that office? What
So
would Glenn do?
Okay, so for me, it depends, not just on the office. For me, it would depend looking at this picture that I showed earlier, which is the New York Times image, this one. I would look at this map in particular, the risk level map. I would either look at this or the hotspots. If I were in a county with a lot of hotspots, then even if I was allowed to be maskless, I would probably still wear a mask. Not because I was afraid of my personal risk, which you could see for the hospitalization risk would be very low, but because I wouldn't want to infect other people. So even if the R value was low, so what we were just looking at here, even if the R value was low, in an enclosed office situation, the R value might have been something similar to 3 originally. So on average, you wouldn't have a big outbreak in the office, but I wouldn't even want to infect anyone else. So if the numbers were high in my county, then I probably would still wear a mask in the office. If the numbers were somewhat low, like they are in much of the rest of the country, then and everyone was vaccinated, fully vaccinated in that company, then I would be more comfortable not wearing a mask, simply because the risk has a lot to do not just with the vaccination rate, but with how many cases are actually spreading in the local community. So go ahead, ask another scenario. I'll answer
Okay.
more quickly.
Okay, WWGD. Okay, so let's say you're living in a household where you have, let's say, one or more children who are under the age of 12 who are not eligible for a vaccine at this moment, or other individuals who are not eligible for a vaccine. What would you do? And what would you do depending on where you live? In that same scenario where your employer did require that everyone was vaccinated to return to work.
So I'm still so it depends on the age of the kid. One thing that we've noticed is that kids who are very, very young, like infants, might be at higher risk from COVID. But if your kid is in elementary school or high school or is not an infant, then their risk from COVID is really, really, really low. And so as a result, if you're vaccinated and your risk of spreading the virus, even if you were to become infected, is so low. Remember, there's 90% less transmission among the vaccinated. So that means that even if you are exposed at work, you have 90% less chance of infecting an unvaccinated kid at home, which means that maybe you could let your guard down. Now, if your kid had some other special thing going on, maybe they were at higher risk for having severe diseases, or they were immunocompromised in some way, or had asthma, or had some other comorbidity that put them at higher risk in some way, then you might want to think twice in terms of their exposing them. But the other thing, again, always going back, is if the caseload is low in your local county, then you need to keep that in mind as well. Right now it's summertime, we need to be enjoying it, except if you're in a county with a lot of spread, then things are maybe different. Like if I were in a county with a lot of spread, even if I were working among a highly vaccinated group, the risk of there being infections is just going to go up just because there's so much virus circulating, just even in the process of commuting to work, potentially stopping at the gas station and around other people. And so therefore, I'd be a little bit more cautious. But again, going back to this idea, if there's 90% less transmission among vaccinated people, that really colors what my thinking a lot in terms of what we would do.
All right, so here's another one. What if the employer does not require vaccination to return to the office?
So
Then
if
what?
it's, yeah, so if it's an area where there's not very many cases, I am still probably mostly fine. I would maybe wear a mask. My biggest interest at that point would be I wouldn't want to infect other people at the office, because even though my risk of transmitting it is low if I were to get infected after being vaccinated, can you imagine being in an office and infecting everyone else in the office? That would be a terrible thing to have on your conscience. So I wouldn't want to be that person. And so therefore, I would probably still wear a mask, even to set a good example, but knowing, even without the example, that if I were infected, I could be, remember, the vaccines are really good at preventing symptoms. So a lot of people are going to be asymptomatically infected and can infect other people around them. They're going to be silent but deadly and infecting non-vaccinated people around them. And that's really a concern that a lot of people are not talking about. So if I were a non-vaccinated person in that office, I would be particularly concerned, particularly if there was a spread, if there was a spike, a surge in their local county, either where they lived or where they worked. I would be, it's not the same situation as it was a year ago or 2 years ago, because now there's going to be a lot more silent but deadly people walking around. And so now it's even maybe more important that the non-vaccinated wear masks, because all these vaccinated people, even if they are less at risk of transmitting the virus, if they have no symptoms and they appear totally fine because they're asymptomatic, they could be spreading the virus like crazy everywhere. And so 90% reduction on an individual level might seem like it's enormous, but if there's 20 people in your office who are potentially at risk, and you just throw the dice over and over again, then a 90%, or the opposite, 10% risk, which is very low, accumulates with the more time you roll the dice. And so then it can actually be an appreciable risk when you look at lots of people.
Okay. Thank you. Thank you for taking us through those different scenarios. Okay, so Glenn, let's wrap up our conversation this evening. There was big news this week, I think we can kind of call it sort of a little bit of a PR issue around the booster shot, and Pfizer kind of coming out and talking about suggesting the booster, and then Fauci saying, well, wait a second, I don't know about that. And the CDC and the NIH saying, well, we don't know. There's not enough data now to suggest that that's necessary at this moment. So where are we? And so let's say many of us on this call have, gotten the second dose or had the J&J vaccine, a number of months at this point ago. And so what are your thoughts around getting this booster? And so what should people be thinking about? At what point should we be starting to think, okay, well, what is our immunity, or where are we vis-a-vis this Delta variant in this? How protected are we? Are these when do these numbers not really hold true any longer? What are your thoughts?
Yeah, that's a really good question. So let's just spend a couple minutes on that. There's also one or two. I know we're only meeting every other week now, so there's like one or two other very quick questions that we can get to after this that I wanted to touch on. But the first answer here is, because these numbers that we're seeing in UK are so good, 96% protective against hospitalization, you can't really get much better than that. I mean, if you wear a mask, if you're that concerned, if you wear a mask, we know that masks prevent the spread by an additional 40 to 50%. So if you're that concerned, then you can drive it maybe up to 98% protection just by wearing the mask. But other than that, that's why there's a lot of pushback that there's probably not a need. It's much more important to reduce the spread by getting the non-vaccinated people who have either only gotten one shot or no shots. Those people, we somehow have to find ways to prioritize getting them vaccinated. However, there's some exceptions to that rule. So generally, people who are over the age of 65, they tend not to have as persistent an immune response when they get vaccinated. And so we're still following people over the age of 65 who were maybe vaccinated back in January to see if they are still going to be sufficiently well protected in January of this coming year. The data is still coming up. We're tracking what's going on in UK. Right now, we're seeing 96%. Oh, Israel, which I didn't get to, is here. Israel was showing slightly worse numbers. In June, they said it was 93% protective against hospitalization. And so we are still tracking this. Right now, the Israel numbers are still not super bad. But so this could be something. If there's other people with comorbidities, maybe the Johnson & Johnson vaccine, which was supposed to be a 1 dose, maybe that might be an opportunity for a booster shot. The other thing would be if there's additional variants that come about. So for instance, we talked about the Lambda variant that is not as contagious as Delta, but when you look at the specific mutations, we realize that there's a couple key mutations that could mutate in Delta that would be very similar to get us to where Lambda is. And so perhaps Delta might be able to escape our vaccine umbrella. And so that might be something to look at. Right now, if the Delta variants that are in common circulation continue, we probably have sufficient protection that we don't need to worry about it. And that's why there's not a huge worry right now. But just given the exceptions that I just said, there's definitely a lot of people looking at this. We'll have a much better idea by August or September whether we should be pursuing booster shots. But like I said, the real big issue is getting more unvaccinated people, getting them vaccinated, because that has a much bigger effect of preventing the spread and ultimately preventing hospitalization. All right, let me just jump back. There were 2 other key questions that people had asked a few times, and I just want to make sure I touch on them. One of them is the masking question. So the CDC came out a while ago and said that people didn't have to wear masks after they were vaccinated, whereas the World Health Organization said, no, people who were vaccinated still need to wear masks. And given everything that I just described, this is the major distinction. The World Health Organization is looking at global information. And so if we're looking at vaccination rates here, people fully vaccinated, here's the map. You can see that much of the world is not very well vaccinated. Brazil, we're looking at 14%. Much of the world, it's not very well vaccinated. Oh, here's a better way. The number of countries over 50% is very, very small. 40 to 50%, you can see that much of the world is not very well vaccinated yet. So from their perspective, if a vaccinated person is walking around without a mask, they're likely to be surrounded by lots and lots of unvaccinated people. And so that means that even if they're asymptomatic, they'll be silent but deadly. And if some of those people infect other people, then you could start these outbreaks among all these unvaccinated people. In contrast, in the United States, where we have a lot of vaccinations, in fact, here's our numbers here. If you're in a county with a lot of vaccinations, so for instance, here's a county with a lot of vaccinations. In this county, this is Coconino County, Arizona, where over 99% of people over the age of 65 are fully vaccinated, and over 66% of 18 and over are fully vaccinated. Then that means among people vaccinated, they're very likely to surround themselves with other people who are mostly vaccinated too. And so therefore, they don't have to wear the masks as much, just because it's much less likely to spread around from there. And so that's the big change in thinking. We just have so much, once the vaccination rates get to a certain level, then you can let your guard down a little bit more. And so I think that's why the CDC is saying what they would. We've described some of the situations and why that might change. There's one other question I wanted to talk about here too this week, because we're not meeting for a couple of weeks. And that was not Lambda. No, was that it? Or was there one more thing? Oh, long COVID. I just wanted to mention this just real briefly. So one thing that we had found, because some people have been asking about that, there was a study that came out looking at are some people more or less likely to get long COVID? And what they found was that people who were infected with mono, and in particular the Epstein-Barr virus, which is actually fairly common, but people who got infected with Epstein-Barr virus and then had a reinfection, and so where it reemerged, were much, much more likely to develop long COVID. So around 2/3 of people with long COVID were positive for having a recent Epstein-Barr virus reactivation, whereas only 10% of people who were not long COVID had this reactivation. So there's something about, it could be correlation, not causation. So it could be that there's something about COVID that triggers a reactivation of Epstein-Barr. But there's something interesting going on. This correlation is interesting, so it's being followed up in further things. I just wanted to mention, a lot of people don't know. So the Epstein-Barr virus is one type of herpes virus. There's lots of different types of herpes virus. When people talk about herpes in general population, they're sometimes talking about the sexually transmitted herpes simplex. But then there's also chickenpox, which is a herpes virus. It's the varicella zoster virus. Then there's also some other ones, cytomegalovirus, and Epstein-Barr virus is just another type of herpes virus. All of these what makes them unique is that they hide in a person. So after a person has an infection, they hide in the person's body, and then they can reinfect the person years later. That's why some people get shingles much later in life, because they might have gotten chickenpox, and then it just reactivates, and it's called shingles later in life. Same thing with Epstein-Barr. It could become reactivated. And so it seems like there's something interesting going on between the reactivation of Epstein-Barr and this long COVID in terms of what's going on. So that's definitely being studied. Right now, there's no cure, there's no treatment for the Epstein-Barr virus to prevent reactivation. There are some things being investigated, but so it's now interesting that maybe those things being investigated for Epstein-Barr reactivation might also now be reevaluated to be repurposed, and maybe they can also be investigated for long COVID. So that's where we are. Thank you very much, Rebecca.
Okay, thank you, Glenn. And just quickly, we just have one quick question from Harry about, okay, Harry, I'm going to ask you to unmute, and then we will wrap up. Harry, are you unmuted? There you are.
So the question is, among people 65 and older that are going to be approaching 1 year after an immunization, at what point are you concerned that there would be a need for a booster? In other words, 1 year being the critical number.
Yeah, so that was an interesting thing. They've been looking among the vaccine trials, they've been following people at the different ages. And what they found so far is that for people over age 65, it seems like the vaccine protection is staying pretty strong so far. So it's only July for the vast majority of the population that has been vaccinated around the January timeframe, between like, I think it was December and like March, where most of the age 65 and over folks were getting vaccinated. So it hasn't been a year, but when you look at the much smaller population in clinical trials, the vaccines have stayed pretty effective. So unlike the flu vaccine, which tends not to last as long, COVID seems like it's lasting a much longer time. The COVID vaccine is lasting a much longer time in terms of protection. It's still being followed. We're going to know for sure by August, September or so. And so that's going to be when we'll find out. So I'll let you know as soon as I know. But for the time being, your protection sounds really great for now. So enjoy the summer. Don't do anything crazy, but it's the vaccines are working really well. So enjoy it.
So the answer to the WWGD is enjoy the summer, particularly if you are in parts of the map where the vaccine level is high and the spread is low. What would Glenn do? Enjoy the summer, but be safe, and generally wear your mask, right? But hold on to the mask is also what you're saying, because the fall and winter is coming, right?
But even the fall and winter is not, I don't think it's going to be as bad in terms of hospitalizations as last year. It could be worse than some people are thinking, but given what I've described so far, I think that we're not going to be hit as bad with hospitalizations among the vaccinated. The unvaccinated are going to be a very different story, and that is still disconcerting. There's a lot of people now that, remember, the risk is much lower among people under the age of 65, but when you just roll the dice so many times, it means that there's going to be a lot of people who get hospitalized.
Oh goodness. Okay, everybody mark your calendars. 2 weeks from today, July 25th, 7 o'clock Eastern time. Thank you, Glenn, as always. We really appreciate all of the hard work you put into preparing our conversations. And thank you to everybody for your questions are always terrific. Really, really keep them coming. And everybody be safe and be well. And enjoy your summer, as Glenn says. See you in
Thanks,
2 weeks.
Rebecca.
Thank
Thanks,
you.
everyone. Bye-bye.
Thank you.
Bye-bye.